Hey everybody, and welcome today to our live stream. I'm lucky to be joined by one of our speakers, our experts, Shelly Denes. Thank you so much for joining me today. We're super excited because today we're talking all about Rehab Summit. If you don't know, Rehab Summit is our annual premier event that we always take place where it's a huge gathering of rehab professionals that come together, connect, network, and share the latest updates in the field. And it's happening in Orlando, Florida this year from August 7th to 10th. You can see that information below. And we're joined by Shelly because Shelly is going to be one of our experts that's going to be presenting. And we're here to talk about connecting the dots between POTS and understanding postural orthostatic tachycardia syndrome. It's something that's often misunderstood and misinterpreted by a lot of rehab professionals, and it's a big topic in the field. And that's why we have Shelly here to chat about it. So, Shelly, the first thing I kind of want to get into is why is it so commonly misunderstood and missed by rehab professionals? And can you kind of talk to it and even share a little bit more about what POTS is for some people that might not understand it?
Okay, well, thank you, Evan. I appreciate you asking me to be here today and that we were going to use this topic. Actually, POTS stands for Postural Orthostatic Tachycardia Syndrome. And I really learned about it more during COVID. Several clients that I had seen and also people that I knew were having difficulty standing for any length of time. And they were getting dizzy. Okay, but it wasn't postural orthostatic or orthostatic hypotension, because what happened is it was secondary to what was going on with the virus that they had. So I started doing a lot of research about POTS, and it ends up rehab clinicians don't really know about it. You don't really see it or you don't know about it. But I'll tell you, physicians, the same thing, because COVID really brought things forward. COVID was a horrible thing in a way. And in a research and medical way, we learned a lot. Okay. So POTS, the interesting thing about POTS is it affects the immune system significantly. So when they get dizzy or somebody can't stand for any length of time, it's not their blood pressure just dropping. What happens is the muscles in the lower legs just aren't reacting. It's not just blood pressure lowered. So what happens is the brain says, oh my God, what the hell's going on? And it sends a message to the heart and says, start beating harder. Come on, let's beat. That's the tachycardia part of it. So then when they get the tachycardia part of it, they get a headache. And this goes on. So it's kind of this cycle they go into. So it's different than postural hypertension. So I started researching a little bit more. And it's interesting that what you have to do with this, number one, you have to make sure that their EKG is okay and that they're, a lot of their vital situations. So that when you see people in your clinic that maybe show these little things, dizziness, a little brain fog, okay, not being able to tolerate standing, and a lot of fatigue, that might be impacting on your rehab progress. And maybe you didn't know that it's POTS. So I think bringing this to the Rehab Summit was an excellent idea, because then maybe when you're in your clinic, you see your patients or sometimes family members, and you're thinking, oh my God, what's kind of going on? You at least know what to see and what to look for. I don't think we learn in school about POTS. At least I didn't, and I've asked other clinicians about it.
Yeah, you raised some really good points there, Shelly, and I appreciate how you took it in differentiating the orthostatic hypotension versus the tachycardia, because clinically and when I was able to work some in the hospital, we would see when you see that orthostatic side, bringing a patient up from laying to a more vertical position, that blood pressure drops in your head, clinically, okay, well, let's go ahead and bring them back down to the to the horizontal position until we're able to progress them. But tachycardia seems different. So I guess my question would be, what kind of interventions or what techniques can you do as opposed to what someone might do with orthostatic hypotension, more for the tachycardic side, when you're getting that elevated heart rate? Are there other things that they should be trying to do to, I guess, help decrease those symptoms? What clinically can you do as like a next step of like, hey, this is, now you're seeing the presentation, how can we kind of try to work backwards from it?
Well, you're asking a very excellent question. And I have to tell you, one of the biggest problems with it is stress or not understanding what's going on. You have a young person, maybe in their 20s or 30s, they have this fatigue, they can't stand for a length of time. And they're getting these heart things, and they're going, oh my God, what's going to go on with this? It's terrible. So one of the things you have to do is you have to reset the autonomic nervous system. That's what you have to do. Because what's happened is they're in fight and flight. The sympathetic nervous system is out of control. Their heart rate's up, their blood pressure's kind of going up and down. It doesn't know they got a headache and whatever. So they're almost like in fight and flight. You can't stay like that. Okay. So instead of just laying down, take their blood pressure, see how they do it. It doesn't work that way. You have to there's a reset. And the biggest reset is explaining to them kind of what's going on. So this is what we need to do. Okay, we're going to lay you down. Okay, just chill. Then, okay, now we got to get your heart rate up because the lower leg isn't doing it. So bring your feet up. Move your feet. I'm using my hands to do that. Knees to chest. Just laying there. And then they sit up off the edge of the bed. And if they get any symptoms, tap their feet. See how they do with that. Laying back down is the worst thing you can do because then you're just falling into what POTS is. They have to reset the autonomic nervous system. Now that might be in one session. You may be able to do that in a half hour. They may have to come back a couple of times, or you may have to go see them, however they are, or a family member. It may take a couple of days to kind of figure this out, but that's what they have to do. That's the start. Then second, if that's working out, then they stand up, walk around a little bit, not too far, because remember, they can't tolerate standing for too long. Maybe go to the other side of the room, sit down in the chair, pump their feet. What I forgot to say is compression hose. Sorry. Compression hose, because you want to get some tone in those lower legs, or a dry fit shirt even, or long, compressions, total stockings. You definitely have to do something in order to get the compression in the lower legs, which is, I'm sorry, I should have said that immediately. Okay. So then they walk to the other side of the room, sit down in the chair, pump their feet. Okay. And you as a clinician are saying, look, you're doing fine. Encourage them. This is how this is the reset we have to do. Then when they're ready, maybe they can come back and go back to where they were on their bed.
Of course. I want to dig a little deeper, and I do have a question, and and I'll kind of play out a hypothetical scenario here. And I think this kind of goes into understanding, and you mentioned this at the beginning, talking about that this syndrome is often sometimes missed by a lot of clinicians, nurses, other people outside of just the rehab profession. So I guess when you're working with these, patients and you see the symptom presentation, and you can recognize, hey, this is POTS, but maybe the nurse doesn't, or maybe a family member doesn't. How then, there's probably a safety range in what sort of vitals you want to work with as far as tachycardia, but how do you then explain to a nurse, like saying, hey, I can work safely with them and through this tachycardia because, laying them down isn't the right option. But I guess, how do you kind of work through that education to let them know that you can safely work with these patients, even though they're having some of these tachycardic syndromes, where maybe a nurse wouldn't understand that and maybe get a little bit more concerned about you wanting to continue a treatment, or same with a family member and working through that. Does that make sense as far as like a hypothetical scenario goes?
Absolutely. So here's the key. I think if you're seeing somebody, let's say they come to you with low back pain, or they have let's say they have a shoulder, ask them, did they have COVID? Okay. This usually will come after a virus, something. It just doesn't show up. Now, if they have underlying like autonomic nerve, if they have autoimmune diseases, they're going to be a little bit more prone to this because that affects the immune system and the autonomic nervous system. And then if they're having symptoms, if you're the least bit concerned as a nurse, as a PT, as an OT, whatever your clinician, I think they need to be referred back to their PCP and say, look, with the education that you have now, I'm talking about us as clinicians, I'm seeing something where I'm concerned that this patient might have postural orthostatic tachycardia syndrome. Then they probably need to be cleared, okay? Because I think me as a PT or an OT or a nurse, unless they're, if that's their area of expertise, we need to make sure that they get cleared by their primary care physician. I think that's key. So you could start like the things that I was talking about and see how they do with it. But you would say, oh, Mr. Jones, I think we need to talk to Dr. So-and-so and make sure that you've been cleared. So there's not a heart attack. There's no clots. Okay. That's the big key. So their tachycardia can go up. Let's say their heart rate's at 80. It can go up to, you can use maximum heart rate, and figure that out. But we're not cardiologists. That stuff needs to be cleared. So I think that's a very key thing in this scenario. And I think, as you mentioned, people haven't known about this. So maybe when a patient's fatigued and they can't stand up too much, maybe you didn't think of this. And there's nothing wrong with the clinician not knowing it, because this POTS is much more well known since COVID.
Yeah, and I think you mentioned some really good points there, and I guess where I want to go next is how as a profession, and not not just PT, it can OT, DC, chiropractors across the board. A lot of rehab professionals that are working with these patients. How do we get better at the early recognition of understanding POTS from both the assessment and evaluation side? Because I can only imagine, someone working with a patient and they're doing an exercise that maybe is a little more rigorous, and their, heart rate's climbing through that. And maybe it becomes a little bit uncontrolled, but then how do is this the exercise, or is this an underlying condition, that could be POTS? So I guess that would be my next question. And that's the mystery in all of this, is how do we get better as a collective profession of rehab professionals at recognizing POTS and understanding how to then, whether we have to go back to the PCP or working through different interventions to help regulating the autonomic system, like you talked about. How do we get better?
Well, I think the education, just understanding what POTS is, that it's affecting the immune system and the autonomic nervous system, understanding the difference between parasympathetic and sympathetic. And, if you're seeing a patient and if you start doing a couple little things I mentioned and that calms down, then we're good. But let's say it doesn't, okay? Their heart rate still stays up. And if they have an underlying cardiac condition, then I think we need to refer them back to the PCP. But you can try the stuff that I was talking about. So let's say what I was talking about, you have them laying down. In other words, they're in a neutral vascular situation, okay? They're not dizzy. Their heart rate seems to be okay. I mean, I don't even think it depends on the clinician. I think taking their heart rate and measuring their blood pressure just makes them more nervous. You have to trust that we're working on this, because then you're making it like it's a big deal, okay? The stress is a huge part of it, because if you're worried about what's going on, which autonomic nervous system is going to work in? Sympathetic. So you stay in fight and flight. So then you can't get through this. So the clinician understanding what POTS is, calming them down. They're laying down, move their feet. Okay, they're feeling okay. Reassure them, sit them up. They do okay. They're feeling it a little bit. They pump their feet. They got those compression hose up. They can get up and walk around the room. Then you're probably good. But let's say they're not resetting the autonomic nervous system. And some of it might be stress, okay? Then I think maybe we need to make a referral back. But how I was going to progress with that is now they can walk to 2 rooms and they're doing okay. Or maybe they can go up and down stairs. So if what you're doing, and incorporate this into whatever the program is. Let's say they're having problems with their shoulder and whatever. Take their mind off of the other thing. So again, I think just how things are looking. And in the discussion that we will have at the Rehab Summit in August in Orlando, I'm going to go over a little bit more detail about POTS, what exactly it is. I mean, I've kind of said some of it, but if the clinician understands what's going on and trusts it, then you kind of know how to progress with that. So I can't say exactly, okay, this needs to refer back to the physician. I think the clinician has to be confident. What I'm dealing with. I would still let the PCP know, because let's say they came and nobody wrote it. because there are some medications sometimes that they can use, and they're supposed to increase their water intake. They have to increase salt. You got to be careful if they have hypertension. It's not just a clear thing like that, but there are some medications that they use and whatever. But the other thing I was going to say, go ahead.
Go right ahead.
What I was going to say, there are a lot of young people, not a lot, but there's a certain amount of young people that have the diagnosis of POTS. It's actually a disease, okay? What I'm talking about in this discussion and what we're referring to now is more a syndrome that kind of happens after a viral incident. And if it's addressed early, then it doesn't become a whole big thing. Then I think they don't get into where they're going to have a disease of POTS.
That's a really good point. Sorry, I don't mean to cut you off. You mentioned so many great things there. A lot of really great points, and I think one that stood out that I really like is you just mentioned how it's important for clinicians and how they talk and communicate with patients and what patients perceive as threat and that stress, and then feeding into that autonomic nervous system. And so I think that's something that it's talked about but gets missed, which is how do we communicate with our patients, and body language matters, words matter. And I think that's really important. You noted on that. And I'm sure you're going to go into so many other great topics on this at Rehab Summit. And for those of you here watching, if you're not already registered, it's not too late to pack your bags and join us. Again, you can see there's a register link at the bottom. That's rehab.pesi.com, Denes RHS24, or register today. Look at top there, point to screen here. There's a little QR code that'll take you right to the registration link. And then also, Shelly, I want to talk too about another session you're going to be doing, which is your spinal cord session. That's going to be really intriguing. If you just want to share a little bit about what that's going to be like, a sneak peek, so to say, for our audience listening in today, because I know that's going to be a really exciting session as well.
Well, thank you. So what I'm, in 2 hours, how much can you cover? Well, you can cover some. What I'm going to try and talk about is some of the syndromes that you see with spinal cord injury, like Brown-Séquard. Brown-Séquard. I'm thinking of the word, what it is.
Yeah, right.
Huh?
Yeah, you had it right.
Brown-Séquard. Okay. Or the anterior portion of the spinal cord is the only part that's involved. And then what do you see? The other key thing is to talk about whether it's lower motor neuron or it's upper motor neuron. Okay. So is it more like a radicular problem, or it's actually the spinal cord's involved and then you have spasticity? Okay. And then I'll talk about how the approaches can be. You can do like compensatory stuff, or some of the newer, where you're trying to get more recovery. So you're still looking for a lot of recovery in the lower extremity or the upper extremities that are affected by spinal cord. So try and go over some of that and really explain how the clinician's going to look at the patient, depending on whether there's lower motor neuron, upper motor neuron, or combination. Brown-Séquard, that's what it's called.
And that's such a critical piece to spinal cord injury.
So that's
understanding.
What we're going to go over, and I will have a lot of references for those clinicians that want a bit more to know about it, because I think most patients that have spinal cord injuries go to select places. They're not seen in the little clinics or hospitals in smaller cities. They go to research facilities because of the extent and the trauma that's involved, usually like that.
Yeah, and it's important to improve access across the board. I couldn't agree more.
Absolutely, for sure. So,
well, Shelly, thank you so much for joining us today. I don't want to give away too much because we have some really great sessions that I know you're going to be speaking to at Rehab Summit. Again, great. You can register with the link below, or you can register with the QR code in the top corner. Shelly, is there anything else you'd like to leave us with today before we?
No, I think that I looked at we have quite a bit of really interesting speakers, so it looks like it's going to be really cool. And James Nestor talking about breath, which is I won't be there till later on that day, so I'm going to miss it. But I think your keynote speaker is pretty cool too. Very, very interesting man, and he does stuff. So that should be great. So looking forward to seeing you and everybody at the Rehab Summit in August.
Wonderful. Shelly, thank you again so much for joining me today.
All right, great.
Sharing